This conference will now be recorded.
Okay, now it is audible. Hello, good morning. Am I audible?
Yes, sir.
Hello, yes?
Yes, sir.
Okay, very good. Yes, sir. So, today we'll discuss perennial. I hope everybody will fine at home, safe on this thing. Today we'll discuss perennial tear. So perennial tear, most of you come across so many times with patient with perennial tear. Either it may be all tear or maybe fresh perennial tear. We'll see immediately after delivery of the baby. That is also. So perennial tear, that is also. First we'll discuss what is perennial tear, what is perennial, how it occurs, and then how you will diagnose it, and then how you will repair it, when you will repair it, and how you will repair it. And at the same time, you will just see the what are the that severity of perennial tear, grade of perennial tear. That's what accordingly you repair all these things. And that is after repair, the most important thing is again, it is the that how to take care of patient post-operative case of perineal tear. So the perineal tear, it is all of you know perineal tear. It is the tear occur during perineum. It is perineum occur during child, mostly during childbirth, all these things. Maybe sometime we may have injury or trauma, something is there, but most of the time it is during the delivery. And particularly unattended delivery. It is not attended. If it is a hospital delivery, and that is also unattended, conducted by dying, all these things. But it doesn't mean that in hospital delivery we don't have perineal tear. We do have perineal tear because sometimes the baby fetus head is very big, or sometimes that rigid perineum like primigravida Remember, head is not properly flexed, deflex head, maybe abnormal position, occiput posterior position. Sometimes that is this thing is excessive mismanagement of that is second stage or first stage or second stage, particularly second stage mismanagement. If properly episiotomy is given, can be avoided, proper support is given, can be avoided, all these things. So there are so many factors, even that rotation is not complete, big baby, all these things. Occiput posterior, particularly pushing the posterior wall of the vaginal wall and causes perineal tear. Sometimes the defective the pelvis, maybe contracted pelvis, android pelvis, or maybe that is that outlet contraction, particularly, and sometimes what is within this contraction, that the symphysis pubic angle, subpubic angle is less. So in this case, it will push further backward and cause perineal tear. And most importantly, when you are applying forceps and that ventouse, instrumental delivery, that is also, that is a cause perineal tear. And some other thing, what is there, that is episiotomy. That is how much episiotomy you are giving, or this type of episiotomy. If it is a posterior episiotomy, midline episiotomy, then chances of perineal tear is there. So it is simple thing, but it has to be taken care appropriate time so that she may not have further complications or some other incontinence or this way. So this is all this thing that is, so that is a perineal tear, that is son. So I already told that repeat delivery of head, it's like precipitate labor, because hardly any time to get sudden stretching of all this thing is of this there. Then sudden stretching of perineum, that's it. Rigid perineum, I told, is a primigravida, mostly in elderly. Young primigravida that are stretchable, but elderly primigravida tissues are not stretchable, rigid perineum, so that it can be, when this force is applied, that baby's force is applied either from forceps or through the fetal head, that is it. Some say earlier that is a healed perineum, healed injury, all these things that is. So these are all these cause, all these things. Few more causes, baby is overweight. So big baby may be diabetes patient, post-dated baby, diabetes, post-dated baby is more important. If it's normal baby, term baby, little bit that there will be that compression of the head is there. That is called molding is there, and that is. But in case of postpartum baby, the modeling is not very appropriate or very good only. So there is problem in molding. So bigger head will be pushing and firmer, bigger and firmer head will push down. That is all this thing. So that will be causing more nulliparity already. That is past there is most of this nulliparity those who have not delivered earlier. The perineum is relatively rigid. All this thing I told you, even elderly patient, it is more rigid than this younger people, let's say young age women. All this outlet contractions, when this outlet contraction, subpubis arc is narrow down all this thing. So head will push downward, face will go downward. So posterior so there will be more pressure on this thing. Shoulder dystocia again, that sometime head will deliver, but shoulder after coming head. The diameter of mitochondria is more than 9.5 centimeter, it is almost 12 centimeter. Though some degree of compression is there, but still wider diameter is coming out and pushing the perineum, pushing the perineum. So it is the shoulder dystocia again, it is this thing. Forceps delivery, I told you forceps, if it is used by experienced person, it is a very safe instrument. But if it is an unexperienced person and little deviation from school, all these things criteria, then it can cause a great damage or maybe very dangerous damage, all these things. So forceps, if it is used by experienced person, it is safe. If it is an unexperienced one, faulty technique of use, again it causes that is dangerous. So pull of the forceps is most commonly pull of the figure without perineal support. We pull of the forceps, the direction the forceps also. So when we use forceps, it is the direction of this obstetric curve, not FLB curve. That is also. So obstetric curve, it is the direction of pull. First, we will pull it downward, forward, and again when that is crosses ischial spine, that occiput is hinges under, then you can extend this thing that is a forward and on forward traction is there. So forceps delivery you can. And it is a timing of forceps. If it is a high forceps, again there may be possibility of tear all these things because of this. So it is it's an outlet forceps is least injurious, but if you are using mid cavity forceps, then it will cause more forceps. Precipitate labor. Precipitate labor, what happens on this? In precipitate labor, what happens? All the events of this will be completed within, that is, within 2 hours or 2 to 3 hours. So that is also quick dilatation, quick all these things. So at that time, no time to just control all these things. So that is also precipitate sudden stretching of this perineum causes of it. Because when there is a lower labor, there is a gradual pushing of this perineal muscle, gradually it stretches all this thing. But suddenly, if you trace, there may be tear, chances of tear. That's why precipitate labor, that is again, sometimes it is not prepared, that doctor is also not prepared to give support, all these things. Midline episode of wall is already it is midline, so it is easily extends directly to the posterior causing complete perineal tear. That is test pubis. I already told you that is. So face to pubis, all these things in occiput posterior, when there is no internal rotation, that the occiput cannot move towards this that symphysis pubis, then we will have face to that the persistent occiput posterior. So if it is baby is adequate, then face to pubis delivery is possible. But if it is not there, then all these things face to pubis delivery, face to pubis delivery, what happened? The wider diameter, that is a 10.5 centimeter diameter, pushing the perineum, that is pushing the perineum. So wider diameter is pushing the perineum, causes scar in the perineum. Again, I told you it is a scar. It is not so elastic, all these things. It is fibrous, all these things. When there is a pressure from fetal head and even if it is force from this forceps, then there may be chances of scar, the chances of perineal tear. That is also. So that is again, that is also. If it is not properly managed in second stage, because normally what happens, if you are giving a person, because you know on this primary gravida, that is on nulliparous hormone, all these things, why the tear is moving? Because it is not there. That's why you give this episiotomy. So ideal time to give it right time, that is also the episiotomy. When head is crowning, it's a delaying episiotomy, there may be chances. If it is episiotomy is very superficial, then also again it is stretch, again it is extension of episiotomy. So it will cause that is very good. So when you are doing that is all this thing is that is a delivery, proper perineal support. Proper perineal support has to be given, that is also, so that it will head will come with control and control this. It is coming in your control, under your control. All these things. If you are putting pressure on perineum, on this, how will give perineal pressure? Take thick gauze pad, the valval pad, thick pad, all these things. Put on perineum. Finger, push your, that is with all this finger or hand, all these things. So that is answer. So baby will deliver control head with control head. That is answer. So that when pressure is giving all these things, simultaneously in forceps also. Forceps advantage of also head will control delivery is possible because you are applying force, but problem will be there if you are putting excessive press. When you are using forceps, that force has to be applied against your elbow. It is not that is always will push forcefully. So control delivery again it prevent perineal tear. That is also. That is also. So these are all these things we have done. That is we have to take care during the labor, all these things. Because we get so many perineal tear because till now also so many people are delivering outside the hospital, maybe home delivery conducted by the inexperienced person. So proper care is not taken all these things. So we may get that is immediate tear and sometimes all perineal tear. That is. So now perineal tear is there. Now we found perineal tear, that is. Then all these things diagnosis. When you will diagnosis perineal, immediately examine the patient, that is after delivery. That's why the examination of the exploration of the vaginal wall, cervix, and perineum is mandatory after each normal delivery. Each normal delivery, particularly instrumental delivery. So when patient is delivered, just immediately after that, when bleeding stops, immediately just put the speculum, see all the perineal tear, see your episiotomy, where is the margin, apex is there, whether it is visible, whether it is extended up to vaginal vault or it is depressed to the rectal mucosa. So immediate examination is sometimes if it is not possible, maybe examine under anesthesia also, or maybe sedation, so that you can explore properly find out the any tear or cervical tear, vaginal lacerations, all these things. So not only tear, you have to see vulval edema, this clitoris, paraurethral injury, all these things. So you have to see whether all these things is any repair or correction is required or not. So when there is there, then you have to see that is a type of perineal tear or degrees of perineal tear. How severe it is, whether it is required by immediate stitch or if it is a superficial, that simple abrasion, you can leave it. But if it is a more degree, again there is incontinence, splatters, fetus, all these things. Though it may not be immediate, you may not know the incontinence, all this, but some degree you can know the degree of that examining the local examination of the perineum. So according to that is the degree of, okay, there are first degree, second degree, and third degree, fourth degree. So these are the all these things you can find with the perineum. So first degree tear is superficial injury. Most of the time it does not cause any problem, maybe one stitch insufficient for all these things. Injury to the perineal skin or mucus vagina mucus, and that is also that is superficial skin injury or laceration, all these things is there. Maybe little bit hematoma, all these things. It may not require stitch, all these things, only better hygienic and allow her to better or allow her to heal spontaneously. Second degree perineal tear, little more injury will be there. This injury to the perineum, that is the skin and some muscles. Some muscles, we know there are so many perineal bladder, so many muscles are attached there. With perineal models, it will receive almost 10 muscles from all sides, all these things. So 10 muscles from the 3 PR muscle, 1 PR muscle, and this muscles there. So we can injury. So second degree tear is injury to the perineum, that is there's a superficial muscle and transverse perineal, deep transverse perineal muscle, that is also. Third degree, again that is third degree injury to the perineum involve the anal sphincter. Here that is. First degree skin, mucus and skin, vaginal mucus, skin. Second degree transverse superficial and deep transverse perineal muscle. Again, you go further deeper, then you'll find anal sphincter. Again, anal sphincter is external anal sphincter and internal anal sphincter. So accordingly, this is, again it is degraded all these things. Less than 50% external anal sphincter thickness is termed. That is also. You see that external anal sphincter, it is less than, it is 3A, not of third degree perineal. That is less than 50. If it is more than, that is 50% anal sphincter is thickness term, that is this again external anal sphincter, internal anal sphincter. Almost all these things is as rectal mucosa is all, rectal muscles is also involved, that is rectal fossa and muscles. And fourth degree injury involving anal sphincter, that is complex external interaction including the epithelium, anal epithelium. So up to the mucosa, it has gone with this, either with mucosa or that submucous layer. So your degree of pressure, first degree, second degree, third degree, and first degree, second degree, third degree, and fourth degree. First degree superficial, that is mucosa and skin. Second degree is transverse perineal muscle. All this thing is there along with skin and mucosa. The third degree, again, anal sphincter is involved, external, internal. There are two people, external, internal, anal sphincter is involved. So that is also again that fourth degree, almost rectal wall is also with or without rectal mucosa. These are the all degrees, all these things. If you see all these things, yeah, that is only superficial tear is there. That is also vaginal mucus is there, little bit anal sphincter is there. In second degree, I tell you can see this is all this thing is second degree. That's transverse muscles is there. Perineal muscles are there. These are the perineal turn out this thing. And that is, this is unaffected, though it is stress, but still it is intact, all these things. Here you see third degree, again this anal sphincter is also most of the superficial, inside it is internal, outside is external anal sphincter, that is in. So here it is a perineal muscle system, that's anal sphincter is also there. Here you'll see that the anal rectum, it is rectum is completely open on this thing. You can see inside this reddish color, so rectum, and outside pinkish color, that is ancestry. So completely, only you'll see septum between vagina and anus or rectum. So thin septum will find. This is all perineal. Immediately, if you see, it is very difficult to, but if it is old one, you can make out. That is only thin septum is present in between vagina and anus. All the muscles are turned. That is also. That is also this is a superficial muscle, deep transverse muscle. That is again sphincter anal muscle. The rectal mucosa is there. So this is the classifications of this tear. That's when everything is done, that is called a complete perineal tear. So I told you all these things is this. So first degree, second degree, third degree, and fourth degree. That is it. So management again, when you that's a diagnosis is important because you can this thing proper diagnosis is important. So diagnosis is important. You have to diagnose this process. Immediately exploration of this vagina, cervix, or the perineum is required. All these things. You say once the bleeding is there, it is difficult to examine you, but you have to stop the bleeding. Maybe suture is required, and this thing is required. So first thing also you have to see all this thing is there. That is also identify the tear, just the stage, the tear, all this, the grade, this tear, which degree tear is there, so that you can plan what type of repair you need, all these things. So first thing is diagnosis, immediately explore on this thing, and again use. So the recognition or type of perineal tear, that is examination of perineal injuries. So they are good source for that. You need good source, big speculum, all these things, exposure ratio. So you have to put the patient in lithotomy position, expose the perineal part, all these things, and see that is the type of injury, all these things. Then exclude the vaginal and rectal exclude associate anal sphincter injury. That is also because when you put the finger in the anal side, there will be grip if this interspinal sphincter is not involved. But if it is there, there is a lack. Though immediately after delivery, there is laxity will be there, but still you can make out. That is immediate. So once it is diagnosis is made, now you have to repair this thing. Thing is that is if the perineal tear is there, when do you repair the perineal tear? When do you repair the perineal tear? That is also. So ideal is there. That is, if you diagnose this immediately after, better to repair then and there, because tissues are healthy. That is a raw. All this thing infection is not there. So identify the injury and the structure and immediately repair is there. So it will be best method to repair immediately. But problem with us is sometimes is deliver outside the hospital, maybe home delivery, maybe small PSC. Their suture material is also not able. All these things, anesthetists are not available. Then they will refer the patient, maybe delayed in this thing. So repair within 24 hours is best. But if it is delayed, again there will be problem. So time of delivery, the time of repair is immediately after delivery, identification and repair all these things. Other thing is if it is delayed more than 24 hours, then again tissues will be friable, all these things, edema, infection will be, healing will be not proper. So leave this patient at least for 3 months. That is a 3 month or minimum 6 weeks. Leave this when all this tissue is because everything is recovered, inflammation is subside, then repair. So repair is time of repair immediately after diagnosis or delivery, or if it is delayed, just again a repair after treatment. This is very clear. That is also immediate repair of the head by immediate reduce the bleeding and pain, prevent edema fibrosis. And tissues are healthy. It's not all these things. So infection is also not here. So antibiotics should be given complete repair after 3 months. I told you it is delayed. Other injury may be little abrasion, laceration, or edematous will be there. It can be dealt with. If the periurethral injury is there, if it is a bleeding stitch is required, all this. So perineal, it includes not only perineal posterior, all these things, clitoris, vulva, all these things. So all these things. So how will repair all these things? So once you diagnose this, one you see that fear is there, all these things. After achieving hemostasis, then you have to repair this. So repair is not at same labor room. So sometimes it is very painful. Painful. Patient has already adjusted to painful repair. If you even whatever if the xylocaine you have given is already effect has gone. So again you have to reinfection. So anesthesia is required. First thing is anesthesia is either regional anesthesia, most of time local infiltration. If it is surgeon is expert, quick within 10 minutes can repair. Local infiltration of 1% xylocaine is easy. If it is not there, then again pudental bone. So the pudental block is there. Pudental block is a block at the level of fluid curtain. We feel it, either pudental block can be given from inside or outside, transperineal or transvaginal. For that block, again, you take xylocaine 1% at least 10 minutes. Either side of the ischial spine, understand that the nerve is pudental, nerve will be there. Pudental nerve will be there. But you have to avoid pudental vessels, all these things. Only around the ischials, infiltrated around 10 ml of 1% xylocaine. Either side. Either it is a transperineal or transvaginal. Put your sterile goggles inside this fill for this ischial spine and transperineally take a long needle, preferably spinal needle, put it inside under your finger guiding and infiltrate there the base. First you withdraw, you are not in the vessels, then if it is not in the vessels, you just push all 10-15 ml. And then procedure is repeated at other side because you have to block both sides pudental. So it is only one thing is there. So repair can be done either it is sedation or local infiltration of pudental. Even if it is a very fast, all these things is there, narrow vagina, all these things that you can give even spinal anesthesia. So anesthesia. Put her in lithotomy position. Put her in lithotomy. Better to steer a position so that the patient will not move here and there. That is it. So that is the first thing you identify the margin of this. And when you will see all these things, then you will see that complete perineal body is lost. Complete perineal body is only thin septum between vagina and anus is detected. So that is it. So dissection not required as in all complete appearance. So first thing is that. So if it is immediate repair, all everything is in fact identification by this muscle, external anal sphincter, and repair accordingly. So that is now you have just it is there. No incision is required. Already tear is pressed, all these things, whatever, only you have to repair it. That is okay, that is your repair. First thing, rectal mucosa is repair. So rectus mucosa is repair for this one. Above downwards, like this episiotomy, you start from the apex of the vagina, all these things on incision, then come down. Okay. So similarly, in rectal mucosa, first you start from apex because apex of this thing. Clean it properly, then you start from apex. Make sure you are taking the apex out. Otherwise, there will be opening over there, it will have a fistula. So first thing is apex and this thing is there. So take apex and then give a suture. That is all. So when you are giving, all book has given all these interrupted sutures, all these things, depending upon length of all this thing tier or depth of tear, you have to take it. If it is a very superficial, the low tear, then you can give continuous, but interrupted. Any distendable organ, better to take interrupted suture. So rectal mucosa, all these things, that is also starting from above till the cutaneous junction. That's it. So till the anal orifice mucosa. So stitch is given on this. The rectal side is over now. So mucosa is stitch all these things. It is first from above downward till the anal office or anal officer. So then again that is. So what you use it, that is a needle should be atraumatic, either 30 or 20 with the bilateral of PDS. You can use all these things. So atraumatic needle is used. Then after completing the rectal mucosa, then all this thing is same suture. Then again it is rectal muscle, that is submusculary or rectal muscle. So that is also suture together. So suture together. Once it is suture together, that is also interrupted. All suture are interrupted. Then you identify and hold the turn end of this anal sphincter. It is very difficult to differentiate the internal and external anal sphincter, but if you are able to identify, take this internal anal sphincter first, and then repair external anal sphincter. That is also. So that is the first is internal, then external. So again, same suture can be given, the interrupted suture can be given. So that is answer. Then internal. Then when you come out all these things, repair all these things, then perineal muscle. That's all. Now you can there's a nipple, the nipple will be there, perineal muscle will be there, and perineal muscle will be there. That again the state of that is it. Now the little, because it is a muscle, little thick muscle is there. Now 10 bilateral or PDS can be used. So little stronger the cell together. Approximate over the sphincter muscle. That is also both sides work together, stitched together. So that is maybe figure of 8 suture is there. So this is there. Then once it is superficial muscle is stitched together, like perineal repair. If there's a hysterectomy, there's a vaginal hysterectomy, we are assessed that here that is doing perineal colpoperineopathy, like this also you'll epoch on this thing. Then once the perineal muscle is stitched, then the vaginal walls, starting from the above downward. Like episiotomy repair, what we'll do, that is also. All this is interrupted suture. If it is a very short one, you can give that is continuous, but ideally as per the book, you can give that is interrupted suture. Interrupted suture, that is also. So this is all this thing repair is the suture material again, that is 10 is there. What this suture is done, that says intercession. I told you in case of fresh injury, no need to exercise all these things. But in case of old injury, then what we have to do is on this thing, that is old injury. So in case of old injury, you have to give incision. You have to give incision. That is also. So when you give incision, again, that is what is where you give from one end to the other end. Again, you will give incision in this area. That is answer. So that is angle. So we'll separate both things because you have to, because it's only thin layer is there between vagina and septum. So incision is given all these things. When you give all these things, it's separated. Flap will be affected. The vaginal flap will be anteriorly and rectal flap will be down. That space is created. When you open up all these things, you'll find some circle. There will be some dimple, all these things, perineal muscles. Identified all these things because when muscle retracted, they'll pull inside. So dimple will identify muscle. Once it is deflected, all these things. So in case of all perineal tear, then again that is also. But when you do for all perineal, all this thing, you have to prepare the patient because we have a time, all these things. So when you're repairing any surgeries, what all these things, what you should make sure patient should be that is a hemoglobin is good. So if it is a anemic patient, improve the hemoglobin. If there is a infection, again you have to treat the infection. That is it. Not only that is the infection from vaginal infection, but also urinary infection. Better you do urine culture, all these things, treat this and cure it, all these things. Because if the infection is there, if you are repairing again, chance of infection will be there. So that is all these things, hematological features, all these things, and tissue should be recovered because there should be no inflammation, edema, all these things. So this thing has to be, patient has to be prepared, pre-operative, bowel preparation is there, all these things. So that after a surgery, you have to manage properly, but post-operative preparation will be easier. If the bowel preparation is not proper, again there is a constipation, all these things, then again there will be, their pressure will be on surgery side on this thing, again there may be, it may give away all these things. So patient has to be prepared, pre-operative, bowel patient, infection, enema, high enema, all these things. After that, you can do all these things. So plan, that is a planned surgery. That is. So give all these things and same way that is mucosa is closed, then again anal sphincter is closed, that's approximated, again perineal muscle is approximated, all these things and vaginal mucosa is there and perineal is there. So a reconstruction perineal body, that is it. Perineal repair is nothing but reconstruction of the perineal. Though it is not 100%, but some degree you can do with perineal. So that is a care after process. As it is important to repair immediately or select the patient or select the time or ideal time of this thing. Like is after care is after surgery, post-operative care is very important. So first thing is all these things, you have first to repair all these things. We just to avoid constipation or large stool or hard stool, all these things. So in this case, what we'll do, better to give her low residual diet. Diet has content of a very small, not a stool, less stool, all these things. So it include milk product, bread, biscuit, egg. These are all these things. If she is eating all these things, hardly any stool will be there. So there will be no. I say a basic idea to prevent the uh, loading of the rectum or to pushing this the pressure over the stitch on this thing. So first thing is low sugar diet like milk, bread, egg, biscuit, fish, sweet, etc. And other thing is you can give that forget sorry that stool softener, that is so that is lactulose can be given all this thing. So that is all this thing is here. That is so stool supply we can give the lactulose. Lactulose what will how will give around 10 8 to 10 ml of urine can be given in night time. Maybe if that is also BD or maybe night time you can give 15 ml or that is also at least for 3 4 days. Avoid that passing of stool, that is also. So that is a laxative. What we are giving is lactulose, maybe BD, or you can give at that time also. Prevent the heart stool, all these things. So again, these are all these things, bowel, all these things. Other thing you have done because it is this side or vagina or anal mucus, that antibiotic has to be given because it is a very contagious species because fetus is coming, is coming. So that you have to give broad spectrum. Not only broad spectrum, you have to give anaerobic also. Anaerobic cover anaerobic like metronidazole. So what antibiotic will give? That is also broad spectrum. 1 to 1.5 gram is given twice daily or maybe thrice daily, depending upon this weight of the body, weight of the patient. Then metronidazole again can be given. That is injectable initially because we don't want to give. That is also. So diet is preferably early we will give the liquid diet, maybe IV fluid. All these things gradually will start as a low residual diet. For first 72 hours, better to give IV fluid, so there will be no stool. All these things. Once it is corrected, then you start with low residual diet, then gradually you start solid diet. So metronidazole, antibiotic, metronidazole, this is. When there is a stitch is healed, again all these things, that gradually will take to do exercise, some exercise, favorite muscle exercise, like raising hand, all these things, contracting perineal muscles, contracting abdominal muscles. It will help all these things, but not immediately after. Once it is healed, then we'll do all these things. So that is so again, that is hygiene. Proper hygiene is there. Proper hygiene has to be maintained. All these things. Not only antibiotic, all these things. I think the betadine cis bath will be very helpful. All these things. Warm water with betadine and sunlight. If we will sit for some time for this thing over there. So the healing will be fast. So any injury perineum to cis bath will be very helpful. So in case of persistent incontinence or colitis, all these things, then again the session should be done. That is the extra thing. Most of the time, almost 80% you can surgery is successful, but some patient may not have that is a proper continence of platters or PPS, etc. Even some residual problem will be there. This problem can be overcome from some exercise, what we are doing on this perineal exercise on this thing. And some may need, some few may need further surgery. In this case, when the second surgery is better to consult, that is this colorectal surgeon or GI surgeon. That will be more useful. Instead of using all these things, better to call senior person or GI surgeon. That is also. So that is all this thing management, all this thing what we are doing for this perineal tear. If immediately detected, better you do all this thing. And when detected, immediate repair. If it is delayed more than 24 hours, that is against this. This is only when there is tear is occurred, not all this thing. But problem with all this thing is that there's a the so how will prevent the perineal tear? That is the important thing. That is the main thing. Because instead of doing surgeries, all these things, post injury, better to prevent injury. So that is all this thing is there. That is good. So plan for all these things, future delivery, all these things. Prevention again, it is all patient has to be instituted delivery all these things. So primary prevention, it is again, this is a subsequent pregnancy prevention. In primary prevention, all these things, what are the etiological factors? It has to be managed properly. If patient is on this thing, and proper conduction of the second stage. When patient is there, if it is a precipitate level, better to put all these things. If it is a very slow, if you identify the occiput, better to go for cesarean section. A selection of the, if it is a very big baby, you better do cesarean section. If it's occiput posterior section, if you have sort of contracted pelvis, that is also you do cesarean section. If it is a borderline, you should be very cautious. You have little delay in the progress of labor. Go for caesarean, unnecessary do it, because nowadays caesarean is more safe, very safe procedure, not like earlier days on this thing. So any suspicious, you interfere and do cesarean section. That is the ideal thing is there. And when there is a proper timing of the episiotomy, when head is crowning. Crowning is when the head is up. What happens normally the patient when there is a crown? I'm telling you crowning when you call crowning. This in each contraction, in each case section, that is a late first stage or during early second stage, baby head will come down and again it is a contraction subside, it's recede back. So during contraction, it will come towards the perineum, even bulges this vaginal occlusion, gaping of the vagina, all these things. And sometimes it is coming and receding. There is a certain point that because it is pushing and it is not receding back. This is called crowning. So why it occurs? Because when it is pushing and pushing and pushing, that occiput hinges after the symphysis pubis. Occiput hinges after the symphysis pubis. That what happens? That is also when it is hinges, they are only not recede. It will not recede back. So that is called crowning. You give episiotomy at the time. And ideal, that is episode should be proper and site of episode. Better to give lateral or mediolateral episode instead of posterior medial. That is answer. So this if your medial episiotomy, that again it will stress on this thing. So this is one thing you give episiotomy if you're there. And perineal support. Perineal support. Perineal support, what? How it helps is, it is when you are doing pushing the head inside the pelvis, it is where including flexion, completion, flexion of this head, all these things. There is a controlling flexion of the head, all these things. So anterior, posterior diameter is vertical. So lesser diameter is emerging out from the perineum. So that is it. That is the reason we have said if you are not giving potential, there may be clear. And when you are giving forceps, again you have to pull the forceps. Again, direction of the force. Again, you remember direction has force should be not very strong. Again, that is only against the level of elbow. No pushing is there. So force is the direction of the force downward, forward, again, downward, forward. So once this episiotomy, that is once the head is delivered, and after coming head, shoulder delivery also has to be taken care. That is all these things you have to do during delivery so that you can. So other thing is when having swimming abnormal. That's what happened. That's after delivery all this thing. Next delivery you plan. Already you have repaired the episiotomy. After that follow up is coming. You see the scar of the episiotomy, how it is doing all this thing. If she is again pregnant, all these things. Okay, depending upon that delivery, normal delivery can be allowed, but very care has to be there. Precaution has to be taken. Otherwise, you go for cesarean section. So you'll see that also. So now there is other method of detecting this antiquity of scar or the perineal muscle through ultrasound, the perineal ultrasound, endoanal ultrasound. You can make out this how good is your stitches and this thing. In this case, if it is any doubt, you can do cesarean section. I already told all these things, occiput versus posterior, occiput posterior. Again, it is because wider diameter is pushing peritoneum. So it has to be delivered in this thing. If you detected early in the labor, better go for cesarean section. So these are all things you have to You have to take care all this thing. And perceived delivery is avoided. That's why sometimes that perceived is also that is a ideal because it will be controlled. Hell will be delivery control, proper control. It is under your control. You can deliver. That is it. That is it. And deliver the head moving content. Because sometimes what is precipice level it push and stretches on this. So I told you perform the episiotomy timely, take care during delivery solvers. This is all this thing because again occiput posterior diameter is 10 centimeter, here again diameter is 12 centimeter. So problem that is also is there. So this is all this thing. That when we see perineal tear, most of the time it is diagnosed immediately after delivery. Sometimes if it is a home delivery, delivery process, if it is not there, there may be. If it is not properly diagnosed, they'll leave a record, they'll come later on as all perineal. So perineal tear is either it is a fresh perineal tear or old perineal tear. If it is a fresh perineal tear, you repair immediately. If it is an old perennial tear, you take and you just allow to heal everything, correct the infection, improve the health condition of the patient, and do after 3 months of this, minimum 3 months, or at least 6 weeks following delivery. So this is all this thing is there, and you should know the degree of perennial tear: first degree, second degree, third degree. First degree, second degree, third degree, and fourth degree. First degree is mucus and skin. It is superficial. Second degree is involvement of the transverse perineal muscles, perineal muscle. The third degree, again, it's anal sphincter or what internal anal sphincter, external anal sphincter, and fourth degree involvement of rectum, either with mucosa or without mucosa. So these are the fourth degree. All these things there. That is also preparation, identification, and post-operative preparation is very important. Post-operative management is very important. First day will give so what will this mean? So the proper correction is required. That there should be no hemostasis is in interest. Septic measure is there. Aseptic measure is there. Proper apposition of the proper stitches is given. All these things. Then post-operative the IV fluid for 72 hours. All these things and antibiotic, both aerobic and anaerobic, both spectrum and metronidazole, and this thing, and proper bowel movement, which is IV fluid for 70, then gradually start low residual diet, then gradually once it is improving, and gradually start the solid diet. So this is all this important, and simultaneously you can better manage with cyst bath with this own reappearance of switch bath can be given on this thing. So this is all this thing you can do. What perineal tear is there. So that is the. This is the complete perineal. We are getting most of the time every alternate examination is complete perineal tear or perineal tear 5 marks the 4 mark questions. So be ready, prepare, read it and prepare a note for on so that you can write in exams. Okay, I think it is covered. I think it is okay. Your this answer. So this ends are perennial tier. That is so okay. Stay home, stay safe. That is answer. And go outside, use mask and this thing. Okay. Bye.